Hi, folks. It's Marvin Muse with MedicareSchool.com, and we want to welcome you to this live event. We're grateful that you have chosen to be a part of our event tonight. A couple things before I get into tonight's topic. Number one, we'd love to know where you're from. I know we have people from all over the country joining in. If you wouldn't mind just putting in there Nashville, Tennessee, Denver, Colorado, wherever you're from, that'd be great. And if you're a client as well, you can let us know. And thank you for really giving us a privilege to be able to serve as your Medicare broker. We are going to cover a topic tonight about plans that people prefer to have whenever they get into a crisis situation. And I'm going to go into the details of that. I want to answer those topics related to that particular subject of picking the right plan. And then as I go through this, you don't have to wait to ask your questions until I'm done. You actually can start putting those questions in on the chat. And I would encourage you to stick around. I told our producer that I will be here as long as I need to answer questions. So hopefully you can stick with us for a while and learn some things. I do want to remind you that not only is it good for you to learn for yourself, but there's a lot of misinformation about Medicare. And we find our clients especially are able to help others to make good Medicare decisions. That really is the goal of our company. And that is to make sure that we as a company are the nation's most trusted resource for Medicare education as well as enrollment assistance. Kind of our mission every day is to make sure that we make the process of Medicare planning, number one, easy and mistake-free. And that really is our goal. And so we'd be privileged to help you in any way that we can. As we go through this tonight, you'll notice an 800 number that's screen. It's 833-833-3661. I mention that because sometimes people need immediate assistance. And so I'm actually in Overland Park, Kansas right now, which is a suburb of Kansas City. And so our offices are still open. We are open, switchboard's open every day, Monday to Thursday, 7 to 7, on Friday, 7 to 6. So you can still call in even for the next couple hours and be able to talk to people within our company that can even provide some additional assistance, really whatever you need. All right, so let's talk about tonight's topic, really preparing for the worst. Which plan is it that people really prefer when they find themselves in a crisis situation? And so I want to begin by saying that you must be mindful that you can't wait for a crisis situation to come and then get on a plan. You have to actually make a decision as you're going on Medicare to prepare for a crisis. So many people think because Medicare has this open enrollment season every year that they can just switch plans willy-nilly, do whatever they want. So they take a cheap plan now, they get cancer in a couple years, well, I can just switch whenever I want. And folks, that is not true. It's absolutely not true. And I share that for this reason. As you make your Medicare planning, you have to put yourself in a position is how will my plan work if I get cancer? How will my plan work if I have to, have, dialysis? So you really have to you have to make plans for a crisis situation in advance. It's kind of like someone that doesn't have homeowners insurance and their home catches on fire. We're not going to call State Farm or Allstate or whoever and say, hey, will you insure me? My house is on fire. They're not going to do that. You had to make that decision in advance. And so as I share this with you, you need to make the right decision because you could have a crisis. In fact, yesterday I shot a video and I found a very interesting statistic. They say now that 95% of all people that are Medicare eligible have at least one chronic condition. 80% of all people on Medicare today have at least two chronic conditions. And so the reality is, as we age, it's really not a matter of if it's going to happen, it's when it's going to happen. And so we really do have to prepare. And that's why we tell people to be educated before you make any kind of Medicare decisions. And that's why we have a YouTube channel. Maybe you met us through there. If you haven't, go there. I have hundreds of videos available. In fact, I shot 2 new videos this week on topics that you can really relate to, things you can learn about as it relates to Medicare and Social Security. And so avail yourself of these educational opportunities to make sure that you make the right choice. So let's talk about your options first, because you have a couple options when you first go on Medicare. One option is to be enrolled in Medicare A and B only, meaning no other plans beyond A and B. Very few people do that. Less than 10% of the Medicare population has A and B only. To me, that is the worst decision. If you ever found yourself in a crisis, that's definitely not what you want. That's a bad choice. Some people do it. So that's A and B alone. Second option you have is to do an A and B enrollment, and you enroll into what we call traditional or original Medicare. And then in addition to that traditional Medicare, you get some type of a supplemental plan. Supplemental plans are designed to fill in the financial gaps that exist within original Medicare. And the way to kind of get your mind around it is remember this: Medicare doesn't cover anything 100% other than preventive services. So if you're going in for some kind of immunization shot, maybe shingles, going in for a wellness exam, those kinds of things, maybe a mammogram for a lady, colonoscopies, those types of things, Medicare covers those at 100% because it's on your list of preventive services. But beyond that, Medicare doesn't cover anything 100%. So there's always a financial liability that you have. We call that a gap. Medicare covers and pays, but not fully. And so you can take those gaps and you can transfer the liability of those gaps to a company called a supplemental company, and they issue to you a policy called the Medicare Supplemental Policy, also called Medigap policies. And so the purpose of buying a gap policy is to take some of the liability that you have and you transfer that to an insurance company, and they're responsible for those bills instead of you. Now, you're still going to have the responsibility, of course, to pay a premium, but if you ever went through a crisis situation, I can assure you that the amount of money that you would pay on your premium is pennies on the dollars that they're going to spend on you if you found yourself in a cancer situation or some kind of serious heart or kidney or lung issue. And so the whole point is people get supplemental plans to transfer the liability of those gaps to the insurance company, and they pay a premium to do that. All right, and so that's one option. I mean, that's the second option. So we have A and B only. We have A and B with a supplemental plan to fill in the gaps. And then we have another option called the Medicare Advantage plan. These have been out and since about 2003, so a little over 20 years now. These are also called C plans or replacement plans. So this is someone who has enrolled into Medicare A and B, but they enrolled with a private health insurance company to replace Medicare for them. And so they have a private health insurance company that is now responsible for them, overseeing their health care, really making decisions for them. That's the Advantage plans. And so about half of all people have Advantage plans today. About 40% have supplemental plans, and 10% have A and B alone. So if I were to rate these three options for you as far as worst to best, I would say if I found myself in a crisis situation, the worst would be A and B. Why? Because you're responsible for so much financial gaps, tremendous amount, because it's unlimited. So if you had a surgery or multiple issues revolving around cancer treatment, you're responsible for 20% of all the bills, and that could really end up in literally $100,000, $200,000 worth of bills, and so a lot of liability in that scenario. If I had a supplemental plan, I can transfer the majority of that liability away, and I would tell you that that is the best option. So if I'm going from one extreme to the other, I think for sure the supplemental plan is going to be your best option if you had some serious issue. Because why? That insurance company that you bought that supplemental plan from, that you pay that monthly premium to, is now responsible for the great majority of those bills. In the middle of those two options, in my opinion, would be a Medicare Advantage plan. Certainly better than A and B by itself, but certainly not as good as a supplemental plan would be. And so let me explain why. Here's a couple reasons why in a crisis situation people love their supplemental plans. Number one, because they can go to any provider that takes Medicare. You never have to worry about, with the supplemental plan, a network. You don't have to worry about HMOs and PPOs. Those exist within Advantage plans, but not so with supplemental plans. So a person has a supplemental plan, can go to any provider, any hospital, any doctor, any surgeon that takes Medicare. And that's going to be about 99% of all doctors and 100% of all hospitals take original Medicare. Therefore, you never have limitations as far as networks go. You can really go anywhere you want. We call that an open access system. So if I'm going through a crisis situation, rest assured, I'm going to the hospital more than likely. Could be an outpatient situation, probably multiple doctors. And I don't ever have to worry about it other than ask them if they take Medicare if I can't go to the doctor that I would prefer to go to. If you had an Advantage plan, it doesn't work that way, because the way Advantage plans work is they're a network plan, HMOs and PPOs. And so networks become issues. I can assure you, you'll never find all doctors taking Advantage plans. Sometimes we'll find a doctor that takes maybe one or two plans in a market and doesn't take the other. Or we may have somebody that's a client that has 5 doctors, and we find 3 or 4 of the doctors in network and 1 or 2 that's not. And so it's very difficult. So people have to switch doctors, find new doctors. We have seen whole hospital groups pull out of Advantage plans. In our market right here in Kansas City right now, the Blue Cross Blue Shield of Kansas City is coming out of the Advantage market. 33,000 people in this area are impacted by that because Blue Cross Blue Shield of Kansas City couldn't make a profit, so they're pulling out. So all those people are going to have to go out and find a new plan and go through the issue of getting new doctors. And so the point is, your providers are going to matter to you in a crisis situation. If you're healthy and really go to the doctor, you're not going to think about it. But if you have a health issue, you're going to care. You want to be able to choose your doctors, not letting the insurance company choose which doctors that you can go to. So in a crisis, number one, you'll like the fact that you have unlimited providers. Number two, the beautiful thing about supplemental plans is they can never interfere in any way with the health care that your doctor believes that you need. We call that a pre-authorization process. Medicare supplemental plans never have pre-authorizations. Advantage companies, 70 to 72% of the time, they do. When you enroll into the Advantage company, what you're agreeing to is to allow them to make the final say-so. That's what pre-authorizations are all about. Your doctor with Advantage plans makes a recommendation, but the insurance company has the final say-so. They have to approve it. If they don't approve it, you're not going to get the service, or at least they're not going to pay for it. If they approve it, it's taken care of. But if not, then you may not get the service, or you just pay for it out of your own pocket. And if you have a serious health issue going on, the last thing you want is an insurance company being able to run interference, being able to intervene, looking over the shoulders of the doctor and making the final decision. And so you would not experience any of those problems if you had that supplemental plan. So that's why I'm saying, you go through a crisis, you'll be glad you have a supplemental plan, because never pre-authorization required by the supplemental company. Why? Because if Medicare pays, they have to follow. They will follow. They have no say-so whatsoever. All right? And then really the next thing I think is very important. When it comes to a crisis situation, you can really run into some great financial responsibilities if you had A and B by itself. But even if you had A and B with that Advantage plan, that replacement plan, the reason people run into problems is because Advantage plans almost always have no premium for the plan, 0 premium to get in the plan. But what happens, instead of paying a premium, you pay as you go. And so if you have a serious health crisis, you're probably going to the hospital. It's going to cost you $350 a day for maybe 5 to 7 days every time you're hospitalized. If you see a specialist, it's probably going to cost you a $50 copay. Every scan you have, CAT scan, MRI, PET scans, going to cost you about $250 per scan. So my point is, if I have a health problem, I'm paying as I go, and more than likely what you're going to do is you're going to max out on that plan. HMO maxes right now are between about $3,000 to $5,000 for the year. PPO plans are anywhere from about $4,000 or $5,000 upwards to maybe $10,000, especially if you go out of the network. And so the point is, I pay as I go until I hit the max out of pocket. And when people have serious health problems, that's when they max out. So let's just say we have a $5,000 annual max out of pocket. That's the most you'll spend. You won't spend $100,000. You'll spend $5,000. But if I compared that to a supplemental plan, and let's say my premium is $125 a month, so that would be what, $1,500 for the whole year. And if you had a plan G, you'd have a small deductible, $240. So I would spend in that scenario about $1,740 for all my premiums and my small deductible. Compared that to my max out of pocket of $5,000. I didn't save any money by being on the Advantage plan. So my point is, when we have crisis situations, there are studies out. Kaiser Family Foundation is a great resource. They'll tell you that you'll spend more money out of pocket on the Advantage plan in a bad health situation than you ever would on your premiums for your supplemental plan. All right, and then lastly, and I'm going to start taking questions, and this is a critical issue that a lot of people are not aware of. You realize that if you enroll into an Advantage plan when you turn 65 or you retire at 67, and you stay on that Advantage plan for, let's say, 2, 3, 4, 5 years or whatever, and you would like to get off of that plan because you're having a health crisis, you're not going to be able to get off that Advantage plan without going through medical underwriting. A lot of people think, I'll go on a plan, I get healthy, I'll switch. It doesn't work that way. Unless you live in New York, Connecticut, Vermont, Maine, or Massachusetts. They're the only 5 states where they have more leniency in what I'm getting ready to teach you. Again, New York, Connecticut, Vermont, Maine, Massachusetts. All the other states, what you have is when you first go on Medicare, again, whether that's at 65 or it's at 67, once you've enrolled into that Medicare B, you have a 6-month window where you can get any Medicare supplemental plan of your choice. 70% of all people today get G's, 30% of all people get N. They're both wonderful, wonderful options. N's a little bit cheaper than the G, and so some people will take that. But again, they're both great. And so what happens when you first go on your Medicare, and that we've set that B date, you have a 6-month window prior to starting Medicare and 6 months after you've started Medicare B, where you have no requirements for underwriting. You can have any plan, any company that you choose that's available in your area. We call that open enrollment or guaranteed issue. No underwriting. That company has to issue that MedSup policy for you. They have to. They can ask no health questions. They're obligated to cover all your pre-existing conditions, and you have just wonderful coverage, no underwriting. But unless you're in one of those 5 states I mentioned, everywhere else, if you want to get a supplemental plan at a later date, now you have to go through medical underwriting. We're going to ask you about 30 to 40 health questions. We're going to check all your medications you take now and into the future. We're going to probably get a statement from your doctor. And that information then, medical information on you, is going to the supplemental company. And they're not obligated to approve the policy. If they don't like something you're taking for meds, or you just got diagnosed with cancer 2 months ago, they're going to decline you. You have AFib in your medical records, they're going to decline you. Insulin-dependent diabetics, very difficult to get you approved. Rheumatoid arthritis, you're going to be declined. Spinal stenosis, you're going to be declined. So there's plenty of medical conditions where the company says, we're not going to take you. So you just missed that opportunity. So that's why I'm saying, as we have this opportunity to make a decision, make the right one and prepare for that crisis in the future. Okay, so hopefully those things are very helpful for you. I'm going to begin to take questions now. And I have someone in the studio that's helping me, so let's start with Debbie. Debbie, you're saying, are premiums individualized? If I go to the doctor a lot or have costly tests performed or surgeries, will my individual premium increase if I use insurance? Okay, and the answer to that is no. You're not. If you take a supplemental plan, what's going to happen, Debbie, is the initial premium in most states is going to be based upon your gender. Most states now, and that may change in the future, but for now, most states we have male and female rates. It's also initial premium is based upon your age. And so they'll base that premium initially upon those factors, where you live, your zip code. So it's gender, age, and zip code, and they establish the price. And then the only way that premium is going to increase has nothing to do with claims at all. Some states allow the insurance company to raise the rate a little bit every year. That's called an attained age increase. And that's going to happen. When we see attained age increase, it's normally about, maybe $50 for the whole year divided by 12. So it's about $3 or $4 a month. So that's an attained age. The other types of policies are called issue age and community rated. And the way they go up is if the whole group goes up. So that would be issue age, community rated. They don't take increases based upon age, only by group. Attained age takes them a little bit every year, and then they also take group increases. So what I'm trying to teach you is they're all going to go up based upon group increases. Now, those group increases always have to be approved by the state insurance commissioner. A company just doesn't raise rates without getting approval by the state insurance commissioner to do that. And so rates are going to go up, but that rate increase, that's the group increase, is going to affect everybody in the group the same. In fact, right before I came into here, I was meeting with a couple, and I was explaining this whole process. You could be in a group, Debbie, and have no health problems, and if the group takes a 5% increase, you're going up 5%. Somebody else could be in the group, and they're in the midst of cancer, and they've cost their group $50,000, $100,000. Well, their rate's going to go up 5% as well. So there's no individualization. Individually, in the beginning, yes, your age, your gender, where you live, but after that, it's going to have to be a group increase that will go up. Has nothing to do with your health. All right. Hopefully that helps. So your use has nothing to do with premium increases. All right, let's keep going. All right, Pam, this is Pam Broker. I'd like to know if the premiums are based on supplemental G plan is based on 2022 or on your current income, because there's a big gap of income in 2024. Okay, well, first off, Pam, supplemental plans have nothing to do with your income at all. They give you a price based upon what I just said, your gender, your age, and where you live. That dictates premiums for supplemental plans. What you're talking about when it comes to income, that has to do with the Medicare Part B premiums. And so what happens if I'm going on Medicare in 2024, they're looking at 2022 income. And that income specifically is called Modified Adjusted Gross Income, MAGI. And if you want to know what that is, just look on your tax return 2022, line 11 and line 2A. And that number then is going to be reported to Medicare, which will from that determine what your Part B premium will be. So we call them thresholds. So we have income thresholds. Again, modified adjusted gross, line 11 plus line 2A. If that total as a single filer is below $103,000, you will pay nothing additional. Married couple files a joint return. If you're below $206,000, you'll pay nothing additional beyond what we call the base premium of Medicare. This year, that's $174.70 a month, $174.70. Now, if you're single and you're above 103 and or a couple above 206, then you're going to pay an additional amount called a surcharge, and it's officially called an IRMA. It's an acronym. IRMA, IRMAA, Income Related Monthly Adjustment Amount. And there's actually 5 levels of IRMAs. I'm not going to give all the details on those right now, but the point is there's 5 levels. And so if I'm above 103 as a single, above 206 as a married couple filing a joint return, then I could have that additional surcharge. The appointment I just finished right before I came into the studio here, he was at $227,000 modified adjusted gross in 2022. He's just now going on to Medicare. And so he had an IRMA on the B. It was $69 and some change. He had an IRMA on his drug plan of $12.90. So it was about $82 for that IRMA. So that's the first lowest level of IRMA. But as we get up, as we make more money, then the IRMAs can increase. So they're on the low side about $80, on the high side about $580. And again, you're going to be making $500,000 or more to have the highest one, but we have these different IRMAs that we have to pay. So that's really what you're talking about. And so if we have no IRMAs, we don't have to have any IRMA on the D or on the B. But if we're high income, then we'll pay more. All right, hope that helps. Let's keep going. Okay, what if I end up in a long-term care facility for years? Does Medicare address the cost of that? Okay, no. Medicare will not cover long-term care expenses. Now, let me clarify something. What you have, Medicare covers things that are certainly some chronic diseases, certainly acute care, all that. But when Medicare is paying the bills, it's because there's something that was more of a short-term situation. Now you may have high blood pressure long term, but they can treat it with meds or whatever. So the point is, it's medical care where there's a high likelihood of recovery. That's what Medicare exists for. This would be diseases, injuries, accidents, illnesses, those kinds of things. When we talk about a long-term care facility, what that is for, that is custodial care. Custodial. Custodial would be things like you need help bathing. Can't bathe yourself. You need help maybe dressing or eating. You need help, you have toileting issues or continence issues, or someone is in a wheelchair and they need help getting from the wheelchair to the bed or into a chair. That's called transferring. So we refer to those as activities of daily living. These are things that are really, I mean, they're important, but these are not medical issues. And so if I want to get those kind of things covered, there's one of 3 ways you do it. You self-pay. You go on Medicaid, and that's going to happen, once you've spent all your money, or you get type of an insurance to actually cover those long-term care expenses. People will get a long-term care policy, traditional long-term care, or they'll get some type of life insurance that's a hybrid that will include some long-term care coverage. But Medicare does not pay for long-term custodial needs. Now, let's go back. Let's say I have dementia. That's going to be custodial because I can't be trusted to take more medications, or maybe I need help with whatever. But let's say I have dementia and I have a heart attack. So I go to the hospital or I go to skilled nursing. Well, now Medicare will cover my custodial needs while they're treating something that's medically necessary. But once I've recovered from that stroke or that whatever it is, now I'm back on my own for my custodial needs. So that's the difference in those two types of plans. All right, let's keep going. Okay, when will the 2024-25 rates come out? Well, I assume what you're talking about would be Med-Sup rates. I'm not sure, Jenny. Med-Sup rates, they really don't come out year to year. Med-Sup rates, when you take a plan, let me just give you an illustration of the people I just met with. We put them on a supplemental plan. They're going to start September 1st of 2024. That rate that he chose, the company he chose, they'll actually lock that rate in for 1 full year. And so what will happen around July, August of next year, if they're going to take a rate increase, they will notify him. So again, it's usually these are based upon effective dates of the policy. Now, if you're talking about Medicare B, the Medicare B premiums, those will come out sometime around October, November range. We should know what Medicare Part B premiums will be. Again, they're $174.70 for people right now, but Medicare is still formulating the numbers as they make their projections for 2025. So those are not out yet, nor are the drug plan rates out yet either. We'll have those probably within the next couple months on drug plans. Okay. Okay, Lola, beside Medicare A and B, I have my emblems Blue Cross through my work. So is that what you call supplemental plan? Because I'm confused. Okay. Let me say this. There is a difference. If you have a Blue Cross Blue Shield plan through your previous employer or even existing employer, but probably previous employer, that would be what we would call secondary to Medicare, because employer plans are not supplemental. Now, they are similar in that if you're retired, then Medicare A and B pays first, and your Blue Cross Blue Shield work plan, prior work plan, would be second to Medicare. But it's still not a supplemental plan, because supplemental plans, there's actually 10 of those. They're all given a letter, A, B, C, D, F, G, K, L, M, and N. There's 10 of those plans. Those are supplemental plans, and those letters and that whole program was basically organized and mandated and standardized by Medicare. So employers, if they continue to have coverage, that's secondary. And so you may have a deductible on the plan or however they cover you, but that again is going to be secondary to Medicare. And if you have a good secondary insurance, their previous employer plan, you really like it, it's not a Medicare Advantage plan, then it could be wonderful for sure. But there is a difference between those. They function in a similar way, but they're still different in the structure of what bills are going to be paid, because secondary insurance, your group plan, that Blue Cross Blue Shield plan you have to work, is going to dictate what's going to be paid. When I have a supplemental plan, it's what's going to be paid is based upon the letter that I actually buy, whether it's a G plan or an N plan or whatever plan. All right, let's keep going. By the way, if you're confused, I'd go to my YouTube channel, MedicareSchool.com. And I think you get a lot of information there. I have an essentials workshop as well on our website full of great information. So the confusion can definitely be cleared up through education. Okay, does Medicare cover orthotics? And the answer to that is yes, they do. I know there are some rules for that, some criteria. And honestly, I'm not well versed in all that. What I always do, James, is when someone asks me a coverage question, I would always put in, Medicare and orthotics or whatever the situation is, and then I'll go through and usually Google it, and there will be plenty of articles about that, and typically something from Medicare as well, saying exactly how they're going to cover that in what fashion. But Medicare is really very, very good coverage. They're going to cover almost everything. They don't cover elective surgery for cosmetic. They don't cover you, like if you go to a chiropractor, they'll pay for the adjustment of the spine, sometimes for acupuncture, but beyond that, they don't do much there. They don't do anything for long-term care, as we talked about. But by and large, Medicare is going to cover almost everything that people need. There are a few exceptions. Okay, let's keep going. All right, I'm at stage 5 kidney failure. I'm on disability. Is there a discount on premium? And the answer is no, there's not. Of course, now, Diana, I don't know how long you've been on disability, but unless you're in New York, Connecticut, Vermont, Maine, or Massachusetts, whatever plan you have now is a plan that you're going to have to stay on for sure. And so, hopefully you're, you're on a Medicare supplemental plan. I would not want to be in stage 5 kidney failure on a Advantage plan for sure. Now, sometimes people that are on disability are below 65, and there's lots of states that you can't even get supplemental plans until you actually turn 65. And so again, Diana, I don't really know about your situation, but discounts on premiums do occur when husband and wife or significant others will be on the same plan, or if you reside with someone that in the home, sometimes you get discounts for that. Those are called household discounts. When there's usually a marriage or significant other, they'll give you about a 5 or 7% discount, but certainly not going to get a discount, because you have stage 5 kidney failure at all. And then if you are below 65, remember this, if you're already on disability, you had a chance to decide what other coverage you wanted based upon the state you're in. But then once you hit 65, you can reset the clock and you'll have a second qualification. So at that time, you can get a standard supplemental plan with no underwriting at all. And it's a second enrollment. We call that an IEP2. And so if you need help on that, by the way, just call our office. We'd be delighted to have that conversation with you, make sure that you got the right plan. All right, let's keep going. Okay, 6-month window. What about 12-month trial right period? Okay, so trial rights really vary on state to state and carrier to carrier. So I'll address the trial right issue. So what that is, and this would be in all states, trial right means that when you first go on Medicare at 65 and you choose to go with an Advantage plan, that's the election you make, which means that your A and B dates are the same. And so let's say it's this in next month. Let's say I'm turning 65 in the month of July. I'm going to go on Medicare, and my A and B dates are 7/1/2024, identical, starting at 65. So what happens is the federal government says that you can try an Advantage plan for a 12-month period of time, or any time in between there, within that 12 months. If you decide you're unhappy with the Advantage plan, or you're concerned about the way they cover something, whatever, during that 12-month trial period of your A and B date, then you can go back to original Medicare and then get a supplemental plan of your choice with no underwriting required. Okay, so that's the one way where I can say dogmatically everyone has a trial right. But you could live in a state where, let's say, you enroll into A only. We have that happen a lot, where people keep working, they enroll into A only, and then they retire 2 years later and pick up B at 2 years later. So my A and B was at 65. My A was at 65, but my B was at 67. Now, in some states, you don't have a trial right. In fact, even for 1 day. And so you would only have 6 months of that B date to get a supplemental plan of your choice. So that's why I'm saying it varies for sure from state to state and carrier to carrier. So trial rights are for everyone that starts at 65, but again, it only lasts 12 months beyond that for sure. Okay, let's keep going. Good question, by the way. All right, is there a copay on Plan G? No. Plan G covers everything except an annual Part B deductible. And this year, that's $240. So you pay a premium for your Plan G, but all the liability is gone except for the Medicare B deductible. Once a year, $240 this year. Last year was $226. I don't know what it'll be in 2025. I also want to mention that some people will get a Plan N. And it does have a couple of copays, not many, but the Plan N is a little cheaper in premium, usually about $30 or $40 a month. And then it does not pay the B deductible, just like the G does not. But with the N plan, you will have a copay up to $20 when you see a doctor or a specialist, and $50 copay when you go to an emergency room. The plans say they can charge you no more than $20 for docs and no more than $50 for an ER. Doctor copay could be on an N plan $12 or $18, but no more than $20. So some people go with an N plan because maybe they're healthy, maybe the state has better rates on N plans, because that happens in a few states. And so they'll opt to save that premium between G and N, but you take on just a little bit more responsibility and the possibility. I want to remind you, if you have an N plan, if you ever incurred an excess charge, rarely does it happen, less than 5% of doctors charge excess. That's the additional 15% they can add to a bill. Again, doesn't happen often, but if you did have an N plan, you would be responsible for excess if and when it occurred. G covers excess, F covers excess, but N and the rest of the plans do not. Okay, let's keep going. What is Plan N or G again? Is that for Medicare? Okay, yeah. Tammy, good question. That's a Medicare supplemental plan. Medicare Advantage, they're called C plans, replacement plans, but Medicare G and N are both supplemental plans. And remember, there are 10 supplemental plans on the market, and I'd say probably 98% of all people are going to buy the G or the N. But there's supplemental plans A, B, C, D, F, G, K, L, M, and N. So you have 10 options, and basically each of those options is a little different. For instance, like the Medicare Supplemental Plan A covers 2 of the 6 gaps. B covers 3 of the 6 gaps. C is not available to anyone unless they're started Medicare before 1/1/2020. It covers 5 of the 6 gaps. G covers 5 of the 6 gaps. Again, very popular today. N covers 4 of the 6 gaps. Plus you have some copays on that. So the whole point is, each of these letters represents a different supplemental plan and a different type of coverage. And I'd encourage you, Tammy, call in, talk to one of our agents. They kind of go through a little bit more of the specifics. And we're brokers, so when we have someone that wants a G or an N, then we're going to shop that market for companies looking for good initial premiums, but also companies that offer good stability of rates. Okay. What about a dual plan and a PPO? Do you still need a supplemental plan in New York City? No. For those of you that are watching, dual plan means that you're dual eligible. You're not only eligible for Medicare A and B, but you're also eligible for Medicaid. And so when you are dual eligible, you really should not get a Medicare supplemental plan because the government's helping you pay for your premiums for your Medicare B, which what happens on dual eligible. They're saying, hey, if you can't meet your B premium, then you can't afford a supplemental plan. So then what you would find is a dual eligible Medicare Advantage plan, and then they do have those on a PPO basis, and that's what I would do. And enroll into a Medicare Advantage plan, that C plan, dual eligible Medicare, Medicaid, and you should have very little, if anything, out of pocket in that kind of a scenario. Okay, so totally different. You're not going to get a supplemental plan if you have an Advantage plan. It's one or the other. All right, let's keep going. Okay, Debbie, I will turn 65 in January, but plan on working until 67. Do I need to pick a plan at 65 or wait to 67? Also, I have glaucoma, so would like to keep my doctor. What would you suggest to be the correct plan? Okay. First off, Debbie, if you're going to keep working, or for those of you watching, if your spouse is going to keep working, either way, and the employer plan that you are covered by has 20 employees on the payroll or more. That's the cutoff. 20 employees on the payroll or more, you don't have to do anything with Medicare. You don't have to enroll in A, and you don't have to enroll in B. Now, if you don't have a health savings account at work, a group plan, I would go ahead and enroll in A only. But if you have an HSA, health savings account, I would not enroll into anything with Medicare because you can no longer contribute to your HSA if you enroll into Medicare. Okay, so if you don't have an HSA, then take A only. That's all I would do in your scenario, Debbie, as long as there's 20 employees at the company payroll or more. If there's 19 or less, then you have to enroll into Medicare. That's a small group, and then the Medicare pays first, and that company insurance pays second. All right, so hopefully that helps you. So you don't have to do anything. If the group is large, enroll in A only. Unless you have an HSA, then do nothing. As far as the glaucoma is concerned, it's not going to be an issue because once you do decide to retire, now you're going to start your Medicare B, and that's when that Medigap open enrollment period starts, 6 months of the B date. You can apply 6 months in advance, or you're still in the window 6 months after, no underwriting required, so they will cover your glaucoma. All right, and let me just share this with you. G and N are wonderful plans. They just both are. You cannot make a mistake. I am 63. I'll be 65 in here in a few months. When I go on Medicare, if I were doing it today, and I'm not, I would still select a G plan. And the only reason is because the difference in premium, that $30 or $40, is not a huge deal. Now listen, if it's $40 on the ground, I'd pick it up. I'm not minimizing $40. But for me, the way I'm wired, I would just soon not have to worry about even the possibility of paying in excess or having to pay some copays. Other people feel differently. They say, no, I want to save the $40, then get an in plan. And if you're saying, I'm not really worried about that, I just soon get as much comprehensive coverage as I can and not worry about anything else, then get a G plan. The only thing you have to do is meet the B deductible once a year. But one is not better than the other. We're all just different. We all have different risk tolerances and different concerns. So just be whatever is, the best that make you happy and give you confidence. So G or N are wonderful, wonderful plans. I don't think either one are bad. So you decide. I just said what I would do. I would do a G plan. Let's keep going. Just signed up for original Medicare and Plan G supplement. If I find I can't afford the G premium a few months down the road, can I switch to the Plan N? Okay, in some states, yes, you can. Okay, those states are called birthday rule states. A birthday rule state, and let me just list them real quickly. I'm going to do this once, and that's it, because I'll probably have another question about birthday rule. But birthday rule states right now, California, Oregon, Washington, Idaho, Nevada, Illinois, Missouri. It's similar, but it's called anniversary, so it's tied to the anniversary of the policy instead of your birth date. Louisiana is a birthday rule state now. Kentucky just became one, and the state of Maryland. And then you have those other 5 states that I mentioned there that also have times where you don't have to worry about underwriting. New York, Connecticut, Vermont, Maine, Massachusetts. So hopefully I named all 16 states. But in these birthday rule states, what happens is around your birthday, sometimes it's from your birthday for the next 90 days, sometimes your birthday next 60 days, sometimes it's 30 days before your birthday, 30 days after, but you have this window of time where you can move from a like policy to a like policy. In other words, you change companies. You can move G to G, N to N, and most of them you can move G to N. And you can make these moves around your birthday in these states with no underwriting. So it's not unlimited unless you're in New York, Connecticut, Vermont, Maine, Massachusetts. They have some more leniency in that. But all the other states that have birthday rules, you can move like to like, G to G, or like to less, G to N. Now, Illinois, you can only do that between the ages of 65 and 75. In that state also, as well as Louisiana, if you make that move, you have to move the same carrier. You can make a plan switch, but you can't switch carriers. All the other states other than Illinois and Louisiana, it is any carrier that makes plans available in your area. Okay, so it is possible. Now, if you're not in any of those 16 states and want to move from a G to an N, you're going to have to medically qualify to make that move. And that's why I would say if that, $40 is something in your budget you don't want to afford, can't afford or don't want to, then I'd start with an N plan. It is not a mistake, okay? Excess charges are very, very rare today. Okay, let's keep going. I'm in northern Utah. My wife and I are both retired. I have Medicare B. My wife kept her employer's group Federal Blue Cross coverage. Do we need a Part B supplement? And the answer to that is no, you don't. So you have FEHB, and that's wonderful coverage. You got Fed Blue. So I think you did, by the way, make a great decision enrolling in B. As you probably know, you didn't have to. Federal employees don't. They can have A only, but I think that's a huge mistake usually. So I think what you've done is well. Now, what I would look at if I were you is what's it cost you all to be on your federal plan? Combined premium, if it's total insurance to them is less than $400 or $500 a month, I'd probably stay. But if you're spending more than that, then I'd probably look at supplemental plans. There's millions and millions of people on supplemental plans, so it really just boils down to what you're paying for the cost. And usually Fed Blue is pretty attractive, so you'll probably stay right where you are. But I have had plenty of federal employees that got off of those plans and just went ahead on traditional Medicare and got a supplemental plan. Now, if you do that, be mindful that you do have to sign a termination notice. You have to get out of that system forever. And so that may cause you to be uncomfortable as well. So don't do it. I mean, you really have good insurance, but you don't need both. You'd be way overinsured, be way too much money if you had a supplemental plan as well. So I would not do that. All right, let's keep going. Just retired from government of several chronic conditions. I was diagnosed with cancer 5 years of service. To keep my federal. Okay, well, you just heard me say that if you were to take a supplemental plan, then you would have to sign a notice that you're terminating your FEHB. And I would be very cautious before I did that. I have had plenty of people do it because they were unhappy with their FEHB options. They were fine going with just a traditional Medicare supplemental plan. But if you're uncomfortable opting out of it permanently, then just what you have is fine. I don't know if you have GEHA or Fed Blue, but that's very good coverage. You also have a drug plan that's built in that as well. So I think that's fine coverage. I will tell you, for those people that have FEHB options that are healthy, we have a lot of people today that stay in that and then will enroll into what's called a Medicare Advantage plan only, MA only. And then the federal government FEHB option, whether GEHA or Blue Cross, will actually coordinate benefits either with A and B, or they'll coordinate benefits with your C plan. Now, the reason people do that is because their federal plan doesn't have any perks included. So you can get a gym membership and some of the benefits that Advantage plans offer. I'm not telling you to do that. I'm just saying there are a lot of people today that will do that because they're healthy and they like the perks. And if they don't like it, they haven't terminated FEHB, they can go back into FEHB and drop their Advantage plan on an annual basis. So it's not a permanent decision like it would be if you went with a supplemental plan. Okay. Now, folks, I know that got kind of weedy. I understand. So if you're confused by that, just call the office. Really, agents will take the time. I've trained them all, so they know exactly how to respond to your questions. Can you explain circumstances that would make? Hey, let's go back on that one. I lost it. Okay, can you explain circumstances that would make Medicaid put a lien or try to use a person's home as collateral for their medical bills? I can. Typically, when I've seen this, it has been because of long-term care facility expenses, and they have the right to do that. And every state's a little bit different, so I'm not sure where you live, but if there ever is a lien, it's normally because that person was enrolled in Medicaid, and Medicaid has the right to recapture the money they spent on someone, and they can do that, through a house. So it does happen, but that would be long-term care expenses paid by Medicaid, and now they're trying to recover those expenses. They have the legal right to do it. Okay, let's keep going. Do I need to shop around every year once I sign up for the Plan G? Jeffrey, most people don't. You can. If you work with us as your broker, we're happy for you to call in on an annual basis, and we'll shop it for you. That's part of our service. But the majority of people find that if they've gone with the right carrier that's stable, then they usually don't have to do that. But we recommend you still, even every 3 to 5 years or so, call us and let's check to see if there's something better. Now remember, you may be in a state where to make that switch you have to medically qualify. So that's why it's important to go with the right carrier, first. Make sure you make that good decision based upon initial premium and also stability of the rates. So you can shop every year if you want. Not required to. Lifetime plans, but we'd be happy to help in that regard as well. Let us know. All right, let's keep going. Can the insurance company raise rates or something in the middle of the year after they had raised it for the year? Okay, Larry, here's the way this works. The majority of carriers only do a rate increase once a year. That is the norm. Once a year. However, what happens in attained age states, attained age, remember I taught this earlier if you were on, attained age means they raise your rate every year because of age. So you're 66, you turn 67, they're going to raise that rate a little bit. And we normally see about $50 a year increase. So you divide that by 12, it's going to go up $4 a month, okay? And then they have the right to do a group increase. So sometimes a carrier will get approved for a group increase mid-year. So if you ever see your rate go up twice, it's because you're in an attained age state, they took an increase when you had a birthday, and then that group increase was approved by the state for the whole group. And so some carriers, they'll even delay the group increase until they take that annual birthday increase. That's the norm, but they do have the right to separate it if they want to. Definitely United Healthcare does that, some other carriers as well. But again, it's still an annual increase. It's just that they split it up for you. It's really the way it works. So, and by the way, I'm not minimizing the pain of increases. We've seen a lot of them this year just because of all, after COVID, people started using services again. Inflation's been terrible, medically. So we're getting hit across the board with almost all the carriers, some worse than others. And then Advantage plans, those of you on them, you're going to see this next year. There's going to be definitely some reduction in benefits and different things going to happen for those plans as well. They're not going to be the best in 2025, I can assure you. Let's keep going. What do you recommend people who have A and B and a Medigap do for vision and dental coverage? Okay, well, what you asked me, what I recommend. I recommend that unless you get glasses regularly, I would not get a vision plan. If you get one, they're cheap. Very inexpensive. iMed's usually $10 or $11 a month add-on. VSP's about $16 a month add-on. So if you want one, get one. But unless you're getting glasses regularly, I see no benefit because original Medicare A and B and your supplemental plan, whatever you have G or an N, is going to give you wonderful coverage for vision. cataracts covered, glaucoma's covered, macular degeneration, wet or dry, is going to be covered. So you're covered well by A and B and your supplemental plan, so that you don't have to have a vision add-on. If you get a vision add-on, again, it's going to cover some money towards or discounts towards contacts and glasses, and gives you one eye exam a year. Medicare doesn't cover eye exams for eyewear, but they cover eye exams for any other reason. Okay, so again, you have great coverage. Now, when it comes to dental, Medicare doesn't cover anything unless it's major. You have cancer, or, going in for a heart valve replacement or something. So I recommend dental plans. And what I would do, first off, I'd see if your dentist offers one. Sometimes they do, and sometimes they're attractive. Otherwise, get some kind of a dental plan. We write a variety of plans, depending upon, what your situation is. Some people want a basic plan, covers about $1,500 worth of comprehensive coverage, and preventive, couple cleanings and a set of x-rays once a year. Others have serious health, teeth problems, and they may want to get a plan that covers $3,000 or $5,000 for the year. What you have to do is pay attention to the details of the plan. The best time to get a a dental plan, is when you're coming off of a group plan, because then you don't have a waiting period. Those companies, as long as you say, I've had a group plan at work, and give us the policy number in the company, then you transition right into an individual dental plan, and you've got great coverage. They normally cover all your basic services, cheap stuff, extraction fillings at 80-20. They pay 80, you pay 20. Major crowns, root canals, implants, those kind of things at 50-50. And they'll set a limit for what they'll spend on you a year, anywhere from about $3,000 to $5,000 a year. And the average right now is probably $45, $50 a month per person for those plans. But again, if you use it, you'll easily get your money back. So get that when you're coming off of a group plan, because no waiting periods. If you wait, then you may not be covered on that plan for 6 months on basic and 12 months on major. And so the best time to do it is when you get ready to retire. All right, so that's my recommendations. I'm turning 65 September. I'm around 30 credits. Now I've med insurance at KP through State Marketplace. Is Plan A and B enough for basic need? Is the last date to enroll for them? Oh boy. Okay. Well, first off, with your 30 credits, around 30 credits, what I would do, first off, I'd apply for Medicaid, because sometimes Medicaid will pay your Part A premium. Because right now, anything below 30 credits, you're going to pay $505 for your Medicare A. If you have above 30 credits, 30 to 39 is $278 a month. And if you qualify for Medicaid, they may pay for your Part A premiums. Again, you're not going to be able to get Medicare B without paying a premium, so that's going to be right now $174.70. So when you say is A and B enough, I assume you're thinking that you are going to pay for A, because if you don't have the credits, you're not going to be able to get A at zero premium unless Medicaid covers that. So yeah, Medicare at KP through State Marketplace. So what's going to happen is this. Here's your situation. Once you're Medicare eligible, then all of the, I assume KP's your Kaiser, all the subsidies that you're getting through the federal government are going to be gone once you turn 65. So you're going to have to pay full price for those plans. The subsidy goes, cost sharing goes. So anyone that's on a marketplace plan is going to lose all those benefits. So I think it would be much better to try to apply for Medicaid. If you can't qualify, then go ahead and pay for your A and B out of pocket. I think you'll be better financially for that. As far as the last day to enroll, in your situation, if you're not working, your birthday's in September. I'm assuming September 2nd to the end of the month. We got October, November, December. So you can enroll as late as December for a January 1 start date. But your problem is your marketplace plan is all the benefits go away at 65. So yeah, you can delay it, but you're in a very risky position. So if I were you, McCoo, I'd be starting my Medicare at 65 and then decide from there if you're going to get an Advantage plan or a supplemental plan, because I'm telling you, the marketplace is going to go away for you. Hopefully you can qualify for Medicaid and get some other options. All right, let's keep going. How do you get coverage for long-term care? For instance, someone with new diagnosis of dementia. Yeah, you can't. There is no way. If you've been diagnosed, someone that you love or you have been diagnosed with dementia, it is too late to get long-term care except for Medicaid. So if you have limited resources, limited income, then you can apply for Medicaid. and then you can get your dementia covered, but you're not going to get through underwriting. Even if you did a hybrid long-term care policy, which meant life insurance, and you have dementia, they're not going to approve you. It really is too late for anything other than Medicaid or self-pay with long-term care expenses. I'm sorry to hear that. Okay. My husband has A and B. Does he need another plan? Well, Pamela, I'm assuming there's no work plan available. So if he has A and B, I think that option is the most risky option. Does he need it? Well, I guess if you all are financially loaded, then he doesn't need it. But even if I was financially loaded, I'd still get another plan. And the reason for that is because you are responsible for 6 gaps with A and B only. And you can go on my YouTube channel. I teach a lot about the gaps. There's 3 gaps on the A, 3 gaps on the B. And so the problem with the gaps is that they never stop. If he had a serious health issue, let's say he had heart issue, had to have operation, you have to pay the doctor 20%, the anesthesiologist is 20%, all the follow-up doctors 20%. So you have a tremendous amount of risk by having A and B only. So I would get a supplemental plan. That's, to me, the best for sure, for all the reasons I've mentioned, but at least get an Advantage plan. And if he's had A and B for a while, he won't be able to get an Advantage plan until probably the open enrollment period. But again, call our office and we can see. Sometimes we have special elections that we are able to take advantage of and get people on plans sooner than the open enrollment season. And if he's healthy, then he can go through underwriting and add that supplemental plan at any time at all. And there's ways to get drug plan coverage pretty immediately as well. So, Pamela, I just would not have A and B only. 10% of the Medicare population has that, but to me, it's just not the best. All right, let's keep going. Do I have to inform Medicare I'm staying on my employer's health insurance if I work past age 65? No, you don't have to at all. In fact, Medicare is really glad that you are not going on Medicare. Now listen, remember, now your employer, there's got to be 20 employees on the payroll or more, and then you don't have to do anything with Medicare. You don't have to notify them. They're fine. They know that when you get ready to retire, you're going to notify them, and then you want to go on Medicare. And then what's key to this is this, roaming Bob. If you worked, let's say, to 67, we're going to have to verify all the way back to 65 that you've had insurance at work or your spouse's work with no gaps in coverage. So listen, if you don't start Medicare at 65, as long as you keep covered by a group plan, even if you're 79 and retire, as long as you've had no gaps in coverage, you will have no problems getting into Medicare. But you can have no gaps at all. So just keep working, keep covered by the plan, 20 or more employees on the payroll, you're good to go. It's fine, stay on that group plan. Now, sometimes people have lousy group plans. I don't know if yours is good or not. If it's good, a good plan to me would be a deductible of $1,500 or less a year, premium of $200 or less a year. Otherwise, if you're paying more than that or have a high deductible, then you can get off the group plan and go on Medicare. A lot of people choose to do that while they're still working, and your employer has to let you do that at 65. All right. Okay, I tell everyone before they make a decision to contact, oh, wow, Elizabeth, may your tribe increase. Hey, we appreciate that very much. And if you know anyone, here's my commitment to you. We will be honest with them, and we will tell them their options, and we will not put pressure on them to make any decisions. So that's the way we treat. When you send people our way, we'll do our very best to take care of them. It's a privilege to be able to serve people, and we take every opportunity. We have it. We're very grateful. So thank you, Elizabeth. All right, turning 65 this year, still going to work until 66 in 10 months. So I know you're born in 1959. Can I sign my wife up for Plan B now? Do you work with veterans? Okay. Well, Mr. Steele, you said for B now. So as long as your wife is 3 months before, a month of, or 3 months after her 65th birthday right now, then you can sign her up for B. If she's covered by your work plan, if you're not paying too much for her to be covered by the work plan, as long as there's 20 or more people in that group, you don't have to sign her up for B, but you certainly can. So we have what we call the initial enrollment period. That's when we start at 65, and that's 3 months before, a month of, 3 months after we turn 65, you can enroll her in B. And if you've been covered by a group plan, then you can enroll her in B anytime you want. And I would do that before you lose the group plan, but you're fine to do that about 90 days up until you retire, as that would be that window. And yes, we do work with veterans. And so with veterans, yeah, just call our 800 number. They're actually the toll-free number on the screen, and there's a couple really extra programs, special programs for veterans, retired civil service as well, and then those that are on TRICARE. There's some unique plan options for them. And so we'd be delighted to tell you about those if you'd like. Just call in and talk to one of our agents. Okay. If you become ineligible for Medicaid, what's the best replacement for dual advantage? Well, if you do lose Medicaid eligibility, depending really upon your budget, what I would do if the budget is still tight, then I would just find a good Medicare Advantage PPO plan, because then at least you have more options, because there's more doctors that take PPOs than HMOs. Now, the best, again, is still supplemental plans, because then you don't worry about pre-authorizations and networks and all those things you got to deal with Advantage. But if you can't afford that extra amount of money in your premium, then get that Medicare Advantage PPO plan, because I think you'll be served better by that than an HMO. And again, I'm not saying HMOs are bad, but I know the networks certainly have restrictions. You can't go out of the network if you want to, unless it's emergency. You're bound to that network. So I have a problem with some of the HMOs for that reason. Plus, sometimes you have to have a referral from your primary care doctor to see a specialist. They have to approve that. And to me, that's annoying. Okay. I retired at 62, 30 years work history. I drew from a 401k to age 67. Will the money I drew from the 401k for IU be used to calculate my Social Security? Okay. So when you talk about Social Security benefit, I don't know if that's really what you're asking, sir, or ma'am, whoever, y'all. Social Security benefit has nothing to do with distributions from 401ks. Social Security benefits are all about how much money we earned during our top 35 years of earnings. So I don't think that's what you're asking for. I think you're saying that income that you drew from your 401k plan, is that going to affect the possibility of you paying an IRMA? And the answer to that is absolutely yes, it is. Okay, so those distributions from 401k plans, 403b, that's all tax deferred. So when you draw that out, that's going to be reported as taxable income on your 1040. It'll be a part of your adjusted gross income. So it is going to have an impact. Yeah, it just is. But at least it doesn't have to last forever. And I don't know if you're single, so if you're above 106,000 modified adjusted gross, or a married joint return above 206, then the impact of those distributions will affect you. But if you're below those numbers still, or you retire, then you can always appeal the IRMAs. Okay? All right, let's keep going. All right, and 64, I'm going to retire 64 and a half. Do you sell plans to cover the 6 months between? Yes, we do. Yeah, you call in and we can talk about Medicare as well as plans that'll make the transition for sure. And there's a couple of different options, and we'd be happy to have that discussion with you. And we have this happen a lot. So sometimes we have somebody turning 65 and the spouse is still 62. We can take care of the 62-year-old as well. Okay, let us know. All right, I currently have only A and B, but plan to enroll in plan soon. I'm still within the 6-month window. My BD, good. Does Medicare cover glaucoma tests? My provider has me do that annually, and the answer is yes, they do. And again, there's a lot of preventive things that Medicare covers, but glaucoma is definitely one of them. And just so you know, if it's some kind of a screening test for glaucoma, it's not like you already have it, but if it's a screening test, some of those are covered at no cost. But even if you're being treated for glaucoma, Medicare will absolutely cover that. Now, without that in plan that you're going to get, then you'd be responsible for 20% of the expenses, because that's going to be covered on the B side. If you get that in plan, then it'll cover that for you, less any kind of small copays you have to the doctor. Okay, so and let's see. So your window, you said May, so you've got. We got to count May, so May, June, July, August, September, October. So be sure, Carolyn, that you don't put that off any later than an enrollment of October 31 for a November 1 start date. Your 6-month window would be over after that. And I can assure you, unless you live in New York, Connecticut, Maine, Massachusetts, you will not get a Medicare supplemental plan with glaucoma. Okay, you will be outside that window, and then you're stuck with an Advantage plan for the rest of your life. Okay, so be sure, don't lose that 6-month window. Let's keep going. All right, our Medicare deductible is tax deductible. Okay. Yes. Any form of medical expenses are going to be tax deductible. But here's the deal, Lori. The only way that people get to deduct, number one, you have to itemize. If you use a standard deduction, you're not going to be able to deduct anything. And the only thing deductible is if, number one, you itemize. But you can only deduct those healthcare expenses that are above 7.5% of your adjusted gross income. Okay, so the first 7.5% of your adjusted gross income, that could not be deductible. So you have to have a lot of medical expenses to be able to exceed that 7.5% of AGI. Okay, and if you have, then the answer to your question is yes. Okay, let's keep going. Please discuss drug coverage under different plans. Okay, okay. So first off, when it comes to Part D plans, those D plans are for self-administered medications. A D plan can be separate. If you get a supplemental plan, we call them standalone plans. D plans can be embedded within the Advantage plan, meaning you get the Advantage plan. It's the MA plan, included within that is a prescription drug plan, so it's all in one. And if you have an Advantage plan, you definitely want to get one with drug coverage unless you're a veteran and can get through VA, TRICARE for Life, or through FEHB. So the majority of you definitely want to select an Advantage plan that has drug coverage within. So my point is, Advantage plans embed drug coverage. Supplemental plans do not. You buy a separate one. Okay, and so again, it's for self-administered meds, because professionally administered meds are going to be covered by A and B or your Advantage plan. And so what happens with these plans now, they've really improved through the years. A drug plan has a formulary, a list of medications covered, and most of them have anywhere from 2,000, 3,000, 4,000 meds covered in a plan. You usually have to meet a deductible. Medicare sets that this year. It's $545. If you don't meet a deductible, it means because the plan has waived the deductible. Sometimes that happens, but we typically have a deductible. And then we have copays. And the good news is this year is that even if you have expensive medications, all drug plans this year are capped at $3,350, $3,350 for the whole year. Had a guy the other day who was on a medication called $16,000 a month. He's not going to spend that. He's going to spend $3,350 for the whole year. I mean, goodness, that medication is going to cost over $180,000 a year. He pays $3,350 because Medicare caps out of pocket for people on D plans. That's why I always tell you, get a D plan, even if you don't take meds. Something can change. You need expensive medication. It's capped by Medicare. Next year, the cap is going to $2,000. So you could be on meds that cost $10,000 a month. Doesn't matter. You're going to spend $2,000 for the whole year. All right. So that's the way they work. So standalone plans could have a premium to them. Sometimes they're low. Medicare Advantage plans are embedded within the coverage. That's the difference. Let's keep going. I'm a newbie to all this, 65 in December, widowed, self-employed. I have Kaiser, California, via color, cover, 55 per month. I like Kaiser. I don't know, begin to decipher. Number one, you can go to my website, or not, website's fine. I have a workshop there, but go to our YouTube channel. But your best situation, call our office. I think California is like our third or fourth largest state as far as business goes in the country. We write lots of business. And sometimes, Kaiser is a good option. Other times, not so much. But we'd be happy to tell you all your options so you can make a very good decision about what you want to do. And December is the date. So what I would do if I were you, let's back up the clock, November, October, September. Yeah, so anytime really within 90 days. Now, the issue with you, though, as well, is that it'd be nice to know what the 2025 plans are going to look like. And they come out October 1. So you can call in now, get some general information, and then probably would set up a second call for you once we know of the 2025 plans. And that way you can make a good decision. All right, let's keep going. I'm on in. I need 30 days of radiation. Is that a charge of 30 times 20? $600, or is it one radiation charge? Someone? No, my understanding is that would be subject to an ongoing copay. However, because I think that treatment is going, I'll put it this way. You are subject to it, but I don't think they're going to bill it that way. I really don't. I don't think it's going to be every time you go in for radiation, because they probably have said, hey, you need 30 days. And I think the treatment plan, I think you only have to pay one copay for that. Do me a favor. I would call I would call the provider and let them know you're on an in plan and ask them that question. Say, are you responsible for a copay each time? And if you cannot get an answer from them, then I would call your insurance company, or if you're a client of ours, call us, and we'll do that with you and for you. Happy to do it. Okay. And so, but I understand why. You're in New York, so you're in open enrollment. So if you find out that you are going to have to pay $20 every time you see the radiologist, I probably would move. But I do know the difference in G and N in New York can be substantial. So, so I can't be more direct on that answer because I don't know that one. Hey, Daniel's our producer. We need to find that out when it comes to radiation. My gut feeling is no, but I'm not positive. Let's keep going. Okay, is dental coming off a group plan the same as discontinuing Medicaid? You know what? I think it can be considered that. I've been told that people that transition off Advantage plans and go back to original Medicare, they can get, they consider the Medicare Advantage built-in component of dental included. So my question to you, though, yeah, I guess that's a tough one. It's a time period to enroll in dental plan and group benefit transition. Okay, I'm not positive about that one. Okay, I've never had that come up. So what you're saying is, yeah, can't be if you have dental with Medicaid, will that be considered group? You can certainly try it. It is what you have, so it certainly doesn't hurt to include that insurance company's information and how long you've had that coverage when you apply for your own standalone dental plan. I certainly would try it. And you can't change it now, just move forward with it, and hopefully they would approve it. Keep going. All right, if you reach age 65, still employed, large company, do you need to register now, or can you wait until full retirement age? Absolutely. Mark, as long as the employer, 20 employees or more on the payroll, you don't have to do anything with Medicare. And if you have an HSA, don't do A, don't do B. If you don't have an HSA and don't see yourself having one over the next couple of years, till you retire, then enroll in A only. Might as well get in the system. Medicare A only pays second to your group plan, but sometimes they pay something. They'll pay co-insurance and they may cover something Medicare didn't. I've seen that happen before. But if you have an HSA you're contributing to, your company is doing it for you, don't do anything at all with Medicare. You can put it off until you get ready to retire. Okay, keep going. Can your team help me with shopping and dental plan? Yeah, absolutely. Just call in. Now, if you need dental only, that's all you're doing, then make sure you tell the receptionist that's all you want. Okay, please. And happy to do that. We have Tier 2 agents that do that for you. Just call in and remember to say, I just want a dental plan. If you're looking at supplemental plan, all those other options, then it'd be a different agent that would handle that situation. But we can help you with that. Just let us know. Okay. All right, do all veterans qualify for drug coverage if you had an honorable discharge? Well, Marie, probably. But here's what you want to do. Contact the VA and ask them what you are eligible for. Because I know eligibility varies, whether there's been some type of a disability, even if it's slight, when you served, how long you served, where you served, all those things go into the equation for VA to determine what you're eligible for. And so always jump through those hoops first, and then you'll know exactly what's going on. And again, most do get drug coverage, but I don't think just honorable discharge is enough. There has to be other criteria that will allow you to be qualified for the VA benefits. Okay. Is there still a donut hole for drug coverage? There is this year. It is very, it's not very impactful though, because Medicare put a cap on out-of-pocket spending this year of $33.50. So yes, it still exists. We still have that third stage of 4. In 2024 and beyond, 2025 and beyond, no donut hole. You have a deductible, you'll have initial coverage, and everything's maxed at $2,000. So yes, this year, a few more months, but again, not very costly like it used to be. Okay. How will the Inflation Reduction Act affect prescription drug plan D? Been told the changes can be profound. Yes. Bill, the positive thing about the Inflation Reduction Act for D plans is they did put a cap on out-of-pocket spending for people on drug plans. But with that, what they did, by putting a cap on it, they transferred the government's liability now to an insurance company. And that's where we're going to see changes. Because you're not going to force a private health insurance company to lose money, at least not very long. So they transferred that liability to the insurance company. So what we're waiting for is to see what's going to happen. Are we going to see premiums go up? Are we going to see formularies shrinking? So we just don't know. The drug plan for 2025 are not out yet, but we are definitely suspecting some turmoil in the market when it comes to drug plans because of the Inflation Reduction Act. I mean, I think their intentions were great. But again, the government's really easy, the government to mandate something and say, you're going to pay for this. Well, you're not going to tell a private health insurance company to pay for something unless they're going to pass on that cost to the consumer. And that's what happens. Makes the politicians look real good, but practically, it's not really going to be in the best interest of most people when they made that decision. Sad. What they ought to be doing is making these drug plans, cut more than just 10. They're looking at 10 drugs a year, 15, and then 20, but it's over time. They just should allow Medicare to immediately begin to negotiate drug prices, and that would have been the greatest thing. But again, they prolonged it for whatever reason. Let's keep going. Okay, again, going from N back to G, need underwriting. Yes. Yeah, the only exception would be New York, Connecticut, Vermont, Maine, Massachusetts. That's it. Okay? Yeah. Everything else, N to G, you're going to have to go through underwriting because you're getting a better plan. You're getting a more comprehensive plan. So in order to make that switch, you're going to have to be approved to do it. Now, if you're still in your 6-month window of your Part B date, you don't have to medically qualify. But after that, you got to go through underwriting. And by the way, if you can't get through underwriting, if you have an N plan, still a very, very good option. Okay. I'm ready. Okay. Retired from government, I have Fed Blue, 500 family per month, 600. Would a G plan be cheaper? Okay, well, it just depends, Richard. When you say family, how many other people are covered by that plan? If it is just you and your wife, then I would tell you for sure going on a G plan is going to be a better value for you. Okay, now if you tell me that you still have children covered by that plan, then that's a whole different element. But $500 a month because you're enrolled in A and B anyway. So what we're talking about would be a G plan or an N plan and a drug plan. So, you can get that you can get an N plan right now. Now, I don't know where you're from, but I mean, sometimes they're $100 a month. Some states a little higher. G plans are about $125, $130 a month. You add a drug plan to that. Even this year, there's several that are zero premium. Even next year, if it's $25, you're still looking at, $300, $400 total. And max out of pocket is that on the G plan, $240 for the whole year. You got $6,500. So you just don't have a good FEHB plan. So that would be someone I'd say, hey, I'd get off that thing, sign the paperwork to terminate your FEHB. They'll stop taking that money out of your annuity, increases your annuity, and just go traditional Medicare with the supplemental plan. That makes sense. Now, if you tell me it's $250 or $300, I'd have a different story. You're just paying too much for that plan. And what's going to happen in the future? I would suspect your Med Sup plans are going to be more rate stable than what your Blue Cross Blue Shield plan is. All right. Yes, you and your wife only. Yeah, you're paying a lot for it. Why don't you call in soon and get some prices in your area to see before you make any quick decisions. But I definitely wouldn't look at it. And the agent you talk with, they'll tell you the truth. If it's in your best interest to stay with the federal plan, they'll tell you. If not, they'll make another recommendation. All righty. What if you cannot find a formulary that has all drugs? Well, here's the issue. There is no formulary that covers all drugs for sure. But there are rules about formularies. If a formulary exists, there has to be at least 2 medications for every disease class that's available. Okay, now, there may be 8 medications that are useful for that disease class. Doesn't mean they're going to have to cover all 8, but they have to have at least 2. Now, we have some diseases, there may only be 1 medication. I can assure you that's going to be in the formulary. But it is difficult to find. There's no plan. I think right now probably I'd say 90 or 95% is about the greatest coverage you're going to get with any Part D plan. But remember, you can always ask for a formulary exception. So if it's a medication that Medicare says should be covered, it's just not by your plan, then ask for a formulary exception and they may add that med to your specific plan for the year. Then you may have to request that again in the future. Did I say anything, or we're all done?
Yeah, we're done.
Okay, clicked off and no goodbye or anything.